In this video, I would like to go over the difference between the presentation of the delirium and dementia and then go over the causes of different one of them. So with delirium, the onset is usually acute, and these patients present with decreased attention and decreased consciousness. And then there would be also hallucinations that are commonly present with the delirium. And then the cause is usually reversible, and it can be caused by the infections, the most common of which is urinary tract infection in elderly. It can be caused by drug intoxication or by drug withdrawal. It can be caused by trauma. It can be caused by fever, dehydration, or medications like benzodiazepine administration in elderly. So that's actually very important. If there is an elderly that is being brought to the psychiatric ward and the patient is agitated, you cannot give them benzodiazepine because that would make them delirious. So you can calm down those patients by administering the haloperidol. Patients with dementia, however, the onset is usually chronic. So think of Alzheimer. It's not like they develop dementia overnight. The onset is usually chronic, and then different causes of it includes the Alzheimer, multi-infarct dementia, Lewy body dementia, Pick's disease, and so on. So I will go over that next. And then the cause is usually not reversible. So if someone develops Alzheimer, for instance, you would not be able to reverse the memory in those patients. However, the attention and consciousness is usually normal. So you can talk to an Alzheimer patient, they look okay, like they may forget, but they would still be able to listen to you and understand what you're telling them. And then they can have presentation of with hallucinations, but hallucinations is usually less common than patients that are delirious. Now next, I would like to go over the common causes of dementia. So the most common cause of dementia is the Alzheimer's disease, and this is caused by either the intracellular accumulation of the amyloid beta plaques or by the accumulation of the extracellular neurofibrillary tangles that are made of the microtubule binding protein called Tau. And then generally, the diagnosis for Alzheimer's disease is clinical. Same with Parkinson. Parkinson and Alzheimer's, the diagnosis is clinical. But then you can strengthen the diagnosis by seeing the MRI of these patients. An MRI will generally show the cortical atrophy as well as the enlargement of the brain ventricles. Common risk factors to the development of the Alzheimer's disease include age, Down syndrome. So amyloid precursor protein, the protein that gives rise to amyloid beta, is located on chromosome 21. So since patients with Down syndrome have 3 copies of the chromosome 21, there's higher chance of mutation in the APP gene, and thus they are at increased risk of developing Alzheimer. And then genetics, such as mutations in the APP, presenilin, as well as the ApoE4 genes, are all associated with the development of the Alzheimer. Now, ApoE4 increases the risk of Alzheimer, but I would also like you to know that ApoE2 gene is actually protective against Alzheimer. So E4 enhances Alzheimer while E2 protects against Alzheimer. And then you should also know that these patients have impaired cortical functioning due to the decreased cholinergic activity. So since there is decreased cholinergic activity in these patients, treatments are generally pointed at increasing the levels of acetylcholine in the brain of these patients. So you can use the choline esterase inhibitor drugs to treat these patients, and these include, for instance, the donepezil, rivastigmine, and galantamine. And then you should also avoid medications that decrease the cholinergic activity in these patients. For instance, tricyclic antidepressants like imipramine should not be used in patients with Alzheimer's disease. And then the second class of medications that is used for severe cases of Alzheimer's disease is called memantine. And memantine is an NMDA receptor antagonist. So by inhibiting the excitotoxicity in the brain of these patients, it is actually neuroprotective and it prevents the further neuronal loss in these patients. So therefore, two classes of medications are used for the treatment of Alzheimer's disease. One is cholinesterase inhibitors like donepezil, rivastigmine, and galantamine. And then the second class is memantine, which is an NMDA receptor antagonist. The next condition of the dementia is multi-infarct dementia, and this is the second most common cause of dementia. And these patients present with the stepwise deterioration in the cognitive function. For instance, they would start to develop deterioration, and then they stay at the level they are for 6 months, and then 6 months later they would have another multi-infarct, as a consequence of which there would be another stepwise decrease in their symptoms. So symptoms keep getting worse, like in a stepwise manner like this. And then the hypertension, so high blood pressure, is a major risk factor to the development of the multi-infarct dementia. And then the best test to diagnose multi-infarct dementia is the MRI of the brain to look for the presence of multi-infarcts. The next disease is the Lewy body dementia, and these patients have features of both Alzheimer and Parkinson disease. So they present with dementia, with frequent falls, as well as with hallucinations. And so hallucinations is due to the hypometabolism in the occipital lobe, and frequent falls is due to the Parkinsonism features of this disorder. So in fact, these patients have aggregates of the alpha-synuclein protein that has been associated with the development of Parkinson's disease. The next condition is the Pick's disease, and these patients present with the aggregation of the tau protein in the frontotemporal lobe of the brain. So this is due to the aggregation of the tau protein in the frontotemporal lobe of the brain. And you may recall that the frontal lobe is important for regulating behavior. And so by affecting the frontal lobe of these patients usually present with dementia and behavioral changes. So if you see a patient that have behavioral changes, then you should think of the Pick's disease. And then the final condition is CJD, also known as spongiform encephalopathy. And these patients develop this disorder due to the presence of the protease resistant prions. So there are proteins that have alpha helix structure, and due to the mutations they would develop into the beta sheet configuration, and the protein that is normal and have alpha helix structure is called PRPC, and then once it acquires mutations is called PRPSC. And this PRPSC would be able to transport to the nervous system via the axons. It keeps on accumulating inside the cells and cause neuronal cell death. So it will cause neuronal cell death upon accumulation. Now, the reason I mentioned that this is protease resistant prions is that it's really hard to destroy these proteins, and one way to destroy them is by autoclaving. So you will have to heat them at about 121 degrees C in the presence of a steam. So just heat itself will not destroy these proteins. And then speaking of autoclaving, it reminds me of spores. So you may recall that bacteria with spores are also highly resistant to destruction, and you will have to autoclave them in order to be able to destroy them. In any case, it's not important for the case of CJD. I just wanted to remind you that autoclaving is used for destruction of prions and spores. Now, these patients generally present with the rapid progression of dementia. So in only a matter of few weeks, these patients usually their symptoms start to get worse and worse. And then one important feature that will help you distinguish CJD from other causes of dementia is the presence of the myoclonus. And then for the diagnosis of the CJD, you will have to use the cerebrospinal fluid and check for the presence of the protein called 1433. So one way you can memorize this number is March 3rd of 2014. So 1433 is the protein that you will have to look for to diagnose CJD in the CSF of patients with this form of dementia. And then finally, I would like to discuss about the mechanism of conversion of the PRPC to PRPSC. So whether a patient digests or there is mutation that causes conversion of the PRPC into PRPSC, this PRPSC, once it comes into contact with any other PRPC protein, it will make them to convert into SC. So it will convert other PRPC proteins into the mutant form, and thus there would be a rapid accumulation, as a consequence of which they would transport into the nervous system, cause a rapid neuronal cell death, and thus the course of this disease is really fast and progressive. So again, the features of dementia associated with CJD, it's a rapid progression, and these patients generally present with the myoclonus. And that concludes our discussion.